Once again, this is Bob Dennis, alias Dr. Bob Dennis, with his colleague, Dr. Stacey Ravid. And we're going to talk today about, take it away, Stacey.
We have several topics we're going to talk about today. The first thing we're going to do, and hello to everyone, is we're going to finish talking about the use of the Micropulse for the lower half of the body. In a previous YouTube video, we had talked about using the Micropulse for many other conditions, and we left off talking about the prostate. So there are quite a few men out there that are using the Micropulse for the prostate, and I wanted to just briefly go over that. It's sometimes a difficult area to get to, but some of the people, some of the men are placing the Micropulse coils down around the bladder area, and they are putting the coils side by side, and they are taping it on the bladder. So as we all know, the bladder's deeper into the body and it's not at the surface, but the Micropulse coils are able to impact organs as well. Another thing that one of the individuals did is he put one coil, one coil on the front and then one coil on the back, and he seemed to think that that worked best for him. So as a matter of fact, since we're down in this area, I want to move on to another use that men are using the Micropulse for, and that's erectile dysfunction. So one participant right now who I'm communicating with twice a month, we're doing a study with this, and he is placing the coils on his penis, and he's using this is an ACE bandage that comes with the Micropulse, and he's found that this has been the most comfortable. He did try the tape, and he said the tape didn't work for him, but this has worked for him. And then he's also used this type of ACE bandage, which is more of a sticky, and it adheres a lot better. Another man that I spoke with, he said that this worked best for using it down there. And putting the coils there, adhering it, and leaving it on for hours. So
I've had a few people tell me how they use it a little differently than what you described. They'll stack the coils and tape them together, and then sort of just sit on it when they're in a chair. Just sit on it right under their perineum.
Okay. Yeah, I was going to get. Yep, a couple of men are using it that way as well. And once again, one of the questions that I have a lot is how do you adhere the coils to areas like that that are difficult to get to? So one of the men is using it for BPH, which is benign prostate hyperplasia. Yep.
I think I always get wrong.
So they're taping it to that area down there, and he is actually sleeping with it. So I have a family member that's been using the Micropulse for that, and he works all day and was not able to wear it during the day. So he started taping it down there, putting on a pair of underwear at nighttime, securing the box. Just make sure that you secure the box and the coils, because you don't want the coils to pull out of the box or tear. And he used an ACE bandage to do that, and he was sleeping with it, and he had improvement with the BPH. So moving on quickly to some female conditions. So menstrual pain. I have spoken with many women that have used the Micropulse for menstrual pain, and basically it's the same principle of placing the coils, taping it, or using an ACE bandage. What I find with women is they are placing the coils on the actual site of pain. So as women, we know that the menstrual pain can be in very different areas. It can also circulate through this whole area. It can move from one side to the other. So the basic thing that women are doing is just placing it on the pain and leaving it for several hours. Want to also let people know that putting the Micropulse on for 30 minutes or less than an hour, if that's all you have, that's great. But really what seems to work best for the Micropulse is if you leave it on for hours at a time. So talking about lower musculoskeletal, many people have used it for knees, myself included. My knees are fine now after using the Micropulse bilaterally on both knees. And what I did was I stacked the coils, taped it, and sat in front of the computer, and then I would switch it to the other knee. What I did when I used that was I tried one knee for about 2 weeks. I had improvement, and then I used it for the other knee. I was doing a little study for myself to see how it worked on knees. And then people are using it for ankle injuries, feet, and toes. I just want to show you all something real quick when you use it for the ankles. What a couple of people are doing who have used it for ankles, myself included, is putting it on either side of the ankle and then using an ACE bandage. Dr. Dennis, would you like to?
Yeah, some people, like for fingers and toes, they like to put the rings around fingers and toes. And I think last time we talked about this briefly, that doesn't seem to work as well as sandwiching the coils above and below the hands and feet and the fingers and toes. That seems to work better than looping the rings around them.
There's one individual who's using the Micropulse right now for their ankles. They have had a long history of ankle injuries and they've been unable to walk. She's pretty much been immobile. She's been on pain medicine every day for a long time. And I just spoke with her recently and she said she used the Micropulse on her ankle the way that I just demonstrated. And she's had 3 days of no pain and 3 days of no pain medication. However, she used the Micropulse on the ankle for about 4 days and called me and said, you know, I'm really not having any relief. And I said, I talked her through it. She wasn't using the Micropulse long enough on the ankles. She was only putting it on for 30 minutes to an hour at one time. I told her to increase it to 3 hours. She did that. And then she called me yesterday to let me know she's had 3 days, no pain.
Yeah, some people do respond in short period of time, but most people, it's better if they can do it frequently for long periods. That's why I went to all the trouble of making it really lightweight, because I think that's the secret of PEMF is like lower intensity for a longer period of time. The idea is that you're trying to hold down the pathologic inflammation long enough for tissue recovery to occur. And that process takes a long time.
So now we are going to move on to a very exciting part of this video, and it's a question and answer with Dr. Dennis. I have spoken with individuals over the last month who've had questions for Dr. Dennis, and without further ado, we are going to begin. Are there any instances of individuals using the Micropulse for diabetes or using it on the pancreas? And if so, placement and duration of coils?
So, first of all, do I look like the answer man? Yeah, actually, apparently I am, right? So this is an area of interest to me. My sister is juvenile diabetic type 1. And, you know, I've been thinking about this problem for a long time. The pancreas is a really deep organ shaped about like this, around, you know, just below like the diaphragm area of the liver, but it's really hard to get at. It's really deep. You know, if you want to get it from behind, you got to go through the spine and all that kind of stuff. So I have long thought that this could be helpful with type 1 diabetes, right? That's what we're talking about, because type 2 diabetes is an entirely different thing. It's a metabolic thing that has to do with you know, insulin cycling. You got plenty of insulin, you're just not, you know, responsive to it. Type 1 diabetes is a different matter. Now, I actually did start, and we had a research project on type 1 diabetes in mice for like the last 3 years from the NIH. We've actually been doing this research. And so mice, they're small enough that it's easy to get to their pancreas. And we found that the Micropulse definitely does change. Some go up and some go down, different cytokines. So there are changes, and there seem to be inflammatory changes in the diabetic mice. But the problem is that the model of what causes diabetes in a mouse is not the same as what seems to cause diabetes in humans. So I don't think it's a very good model for preventing diabetes in mice, because it's something that's kind of it's caused, the insulitis is caused by a specific genetic mutation that it's not like what's in humans, at least not with the mouse model we were using. There's not really a particularly good animal model for diabetes, in my opinion. We looked at the ones that are available. This is a perennial problem with animal research, other than the fact that animal research is somewhat objectable. I personally don't like to do it, but I understand the need for it, right? But one of the problems with it is that animal models of disease are very often completely different than human models of disease. And this is why we keep curing cancer in rats and mice, and then it never works in humans. This is something, it's almost a joke now. For the last 20 years, we can never get stuff to work. And so there are probably many, almost certainly, I would bet money on it, many perfectly good treatments for humans that didn't work for animals at all, didn't work in our models. So that's kind of like a broad statement about this. But narrowing it down to the original question, yeah, we've done funded NIH research on this. We're seeing changes in the inflammatory cytokines, in the animals that are type 1 diabetic, but have not been able to test this on people. Just have not been able to. The idea that I have for it is that insulitis is the immune reaction to your own insulin that causes your body to kill the islet cells in your pancreas that causes you to be unable to make diabetes. That's a transient event that happens when you're like a young, you sort of like a 10, 11, 12-year-old child. And it only happens for a while, but it happens for long enough for your body to kill off these things called islet cells. All right. Now, my strategy was, if you could detect this early enough, could you reduce the pathologic, immune attack? And this has been tested in animals anyway. What they'll do is they'll do like immune suppressive drugs, and they can actually rescue type 1 diabetic mice, because they can stop them from autoimmune destruction of their own islet cells long enough for the mice to grow out of it. So the idea that I've had for years is that you use the Micropulse to pull human beings through this period where they're sort of basically allergic to their own insulin. And then if they can come out the other side with some islet cells, then they'll be still able to make their own insulin, and therefore they won't be type 1 diabetic.
Great idea, Bob.
What's that?
Great idea, Bob.
We've never been able to test it. I've been wanting to test that for probably 8 or 10 years now. We tried testing it on mice. We did see changes in the cytokines, but it was inconclusive. And once you have lost those cells, I don't see how we can reverse type 1 diabetes. So once it's gone from the sort of acute to chronic phase, I don't see how to reverse it. However, I've been wrong about this kind of thing. People have told me, many people now have told me they've been able to reverse Parkinsonism. And Parkinsonism is a death of substantia nigra cells in your brain. And once you go below the baseline level, once you go below about 20% of what you're born with, you start to exhibit signs of Parkinson's. And so it didn't seem to me like PEMF should be helpful at all because those cells are already dead. However, it seems to be helpful. People seem to regain function and everything. I don't know if the cells are regrowing or if the change in the inflammatory state is making it possible for a smaller percentage of cells to, sustain a reasonable level of function. I don't know what it is, but it's some kind of trade-off between cells being able to actually regenerate, which I don't have any evidence for, versus changing the inflammatory state in either the brain in the case of Parkinson's or the pancreas in the case of type 1 diabetes, so that what few cells you do have left at least can do the function that they're supposed to do without being under constant attack. But I don't have any evidence for this. These things are really hard to do research on, and my area of specialty is more like musculoskeletal, so it's really hard for me to start collaborations in other organ systems. I have a similar thought about liver disease. And I think we should be able to slow down or even reverse some forms of liver disease. And I have been trying for more than 10 years to get a scholarly collaboration to work on that. But people are very resistant. Academic researchers, they're like, do you have money? Are you bringing a grant? And if you don't have a grant, they don't want to talk to you. It's surprising, but they want the money up front.
So using the Micropulse for the pancreas, if someone was going to try it, where do you think would be the best place to put the coils, and what setting?
This is how I would do it if I were experimenting. If they're sort of a slender person, I would put coils on opposite sides, right at the base of the rib cage, one in the back, one in the front, bumps away from the skin. And I would use a pretty high setting because you got to penetrate through a lot of tissue.
So on the M1, what would be the highest setting?
I would say, like a 13, 14, 15 intensity. On the A9, I would use the X, the extreme setting. Same for the C5, same as the M1, a 13, 14, or 15. Coils on opposite sides if it's a slender person. If you're really heavy, then you probably want to stack the coils and put them right on your spine, right where the front sort of the, it's good to look up. You can find anatomy of, human anatomy online now, but, find where the pancreas is with respect to, find an illustration where it is with respect to the rib cage and put it right over that area on your back. Maybe have somebody place it there.
Can you just show us quickly how to stack the coils again properly?
Yeah, stacking the coils is pretty easy. Think of them as like poker chips. Put the sort of ridges together. That's the way I stack them.
Okay.
Just put them together like poker chips like that. And that's because the coils are opposite wound, so that when the bumpy side, and this is a north and the bumpy side and that one's a south, or vice versa. So they're always opposite magnetic polarity. And so, if you put them bumps to bumps and then tape them together, that's correct.
Quick question. If you did it smooth side to bumpy side, would it still work?
Yeah, it still works, but it mostly cancels the field out. But
Okay.
what's interesting is it doesn't take a lot of intensity for this to work. And there are some people who swear by it. They say, oh, no, that works better. What they're really saying is they respond to a very low intensity, because too much intensity doesn't work as well. That's why I always tell people start in the middle.
Okay. Okay, good. All right. Well, that is terrific. Do you know anybody who has used the Micropulse for their pancreas or diabetes?
I don't know anybody personally.
Okay. Myself included. Of all the people I've interviewed for the dissertation and talked to since then, I do not know anyone. I do have an individual right now who's willing to try it for diabetes. So I'll get back to you on that. So if people were going to use the Micropulse on the kidneys, can you just talk about placement on the kidneys?
What
And
seems to help people a lot, and people have had two different strategies. Kidneys are a little bit closer to the surface than pancreas. and they're up higher on the back than most people think. So you want to, once again, find an anatomical drawing of a person and realize where you need to be, just not too far below where the rib cage stops on your back. And they're on the right side and the left side for most people, a couple inches to the right and left of the spinal cord, a little more than that actually. And some people will put one coil over each kidney, and sometimes people will stack the coils, put them over one for a while, then put them over the other one for like an hour or two, each. So those two strategies, and from what I've heard from people, those actually work pretty well. Now, does it work for kidney stones? I don't know, but a couple of people have told me it's helpful in passing them.
Yeah, I've spoken with people that have used it for kidney stones.
Yeah, it reduces the inflammation, and I guess then it's easier for them to pass stones. That's what people have told me, but I don't know.
Okay. Your knowledge, here's a big one, and description of what the Micropulse does on a cellular level.
That is the magical question. That when someone tells you they know that, in my opinion, they're lying to you. I have read everything about PEMF written by everyone in every language that you can get a hold of for the last 30 years. Well, 20 years anyway, 25 years. Nobody knows. Nobody's proven it. But there are lots of theories about it, from quantum caging and just everything. I've spoken with quantum physicists who have theories about this. There are physiologists who have theories about it. There's a lot of quacks that have theories about it. I get asked almost weekly. A guy sent me about 15 messages yesterday asking me to help him sort through all of this. And then he just started throwing these random science words. So when you start to hear things like 0-point energy and quantum coupling and stuff like that, let me tell you, those are real things. Those seem to be real things. But to get quantum coupling to work takes an entire laboratory with millions of dollars worth of equipment. And we can only get like a photon to couple once or twice here or there. And it's like, there's no way that some person went out into their garage with a soldering iron and built something like that. So don't believe any of that stuff. People will tell you about tachyons and quantum fields and Schumann resonances. Schumann resonance is real. It's a real climatic phenomenon in the ionosphere of the Earth, responding to lightning strikes on Earth. But it's incredibly hard to detect. Once again, you need a whole room full of equipment to detect it. There's no way that somebody's selling you a PEMF system that can detect it. So I estimate 95% of the information on the internet telling you how PEMF works at a cellular level is either pure speculation or fraud, mostly fraud, because people are trying to sell things. Okay, so let me tell you what, and I've made many videos about this. You can, just type in Bob Dennis PEMF, and you can watch me talking about this for hours and hours and hours. But briefly speaking, we really do understand very well, since the work I did at NASA, we really do understand very well the first half of it, the electromagnetic half, how to make a waveform that does have a biological effect. We were able to pretty well nail that down. We know how to make all the electronics. We know how to make the waveform. We know how to project it into the tissue. We do not know how cells detect it. But I have a theory about that, and I will tell you about that in just a minute. Once the cells detect it, we've got a fairly good amount of information in the form of about 1,000 published papers telling you what it does biologically. But that one little step in the center, the transduction step, we don't know. Now, does that mean you shouldn't use PEMF? Here's the reality. Most things in medicine really don't know how they work. Oh, they'll tell you, because no drug manufacturer, no device manufacturer wants to say, well, we really don't know how it works, but go ahead and buy it, right? And usually when I give talks with a lot of doctors in the room, I'll ask them, would you do a procedure? Would you give a drug or do a procedure where you had no idea what the mechanism was? And most doctors are like, harumph, balls or dash, I would never do such a thing. And then I ask them, okay, have you ever used or referred someone to the use of anesthesia. That's my go-to. Anesthesia is one of the three great pillars of modern medicine. You've got, like, the big ones are like, include one of the biggest ones is anesthesia, because like something like 300 million people use it. 350 million people every year are able to have surgeries because we have, local and general anesthesia. It's not safe, but it's a lot safer than not getting surgeries sometimes. This is one of these things, right? We don't know how it works, and I can prove it to you right now. We don't have any idea what the mechanism of anesthesia is, because what does anesthesia do? It does one thing. It alters the memory and consciousness of pain. You do not go through the trauma of having somebody do surgery on you while you're awake and aware. That people can't recover from that many times. It's like PTSD. It has to alter your memory and your consciousness of pain. And here's the problem. We don't know the mechanism of memory. We don't know the mechanism of consciousness. In fact, we don't even have an agreed upon definition of consciousness. How could we possibly know how a substance alters the memory and consciousness of pain? Well, we can't. By definition, we can't, because we don't even understand two of the three key words in what anesthesia does. So a lot of people would like to say to you, well, if you don't know the mechanism of PEMF, then you shouldn't use it. Well, the thing is, we don't know the mechanism of almost everything we use in medicine. Anesthesia is just a great, if you look it up, type into Google search, anesthesia medical mystery, you'll find paper after paper, people discussing it. There's theories about it. And every 5 or 10 years, somebody will give you the, aha, we figured out how it works. And then they'll do some sort of like, here's a molecule in it. It's a lock and key and it does this. But it doesn't actually explain how it affects memory or consciousness of pain. It does not. It's just one more little thing that has to do with the chemical structure. Most drugs, we do not know what they do. And the problem is that most of them do many things biologically. Sometimes they do what you want. Very often they do a lot of things you don't want, right? I mean, I know Stacey and I agree on this point pretty strongly. Stay away from them unless you absolutely need them. So that's the thing. Do we know what is happening between a magnetic field and a cell? Because it's at the level of a tissue, it's going to be a cell has to respond. The answer is we don't know. There are dozens of theories about this, but my theory, which I don't think anyone has posited yet, and I've written about this and I've put it out there, is that PEMF works by electromagnetic induction, which means that a magnetic field either expands or collapses, and when it does, it causes an electric field. And you can calculate this. You can calculate that any magnetic pulse must cause an electric field in the tissue. And where that electric field will cause a current is wherever there's conductive media. That's like cytoplasm, it's like intercellular fluid, intracellular fluid as well. So what an inductive pulse will cause, and this is just known physics, it must do this. Whether or not this is what the cells are detecting is a different question, but you can calculate this. It's a mathematical certainty that when you pulse a magnetic field, you're causing ions to move along paths where the ions can move. Mm-hmm. And so that would be along cell membranes, along the membranes of organelles, between cells. And what we do not know yet is how the body detects the movement of ions between cells. We know how we detect ion movement across cell membranes. We have a good device for that, but we don't have good measurement devices for detecting ion movement around and between cells. And I predict that when somebody figures that out, they're going to get a Nobel Prize, because that's a whole area of signaling that's just not understood. Mm-hmm. For example, getting up and walking is a lot healthier than sitting, mm-hmm. even though you don't have to exert yourself too much. Why is that? The theory is that while you're walking, you're squeezing these intracellular fluids around in your knees and between your cells, and those things carry ions, salt ions, and those movement of those ions can be detected. This has been a big question ever since I was in grad school, even before that. How is it that the body can tell the difference between movement, even passive movement, versus slow movement. There's a huge difference in your health outcome.
Right.
And part of the answer to that might just be the movement of ions. So my hypothesis, essentially, subject to testing and proof, is that PEMF is an inductive process that causes the movement of ions between and around cells, extracellularly and intracellularly. So it's going to happen around the nucleus, around Golgi, apparatus, just everything inside of a cell and outside of a cell. Wherever there's a continuity of fluid with ions in it, those ions are going to move. They must. And so that's an easy question to ask. It's sort of like asking, why is the sky blue? I can tell you exactly why the sky is blue, but it would take about a half an hour.
That was a fascinating answer to that question. I knew some of it, but I just learned a lot of things that I didn't know. That is a question that I get frequently from people, is how it works on a cellular level. So what we're going to do for the next video is we are going to go over the protocols for the different micropulses. Many people have had questions about the protocols and what they're used for, the settings. So we are going to cover that in a question answer session with Dr. Dennis next time. Thank you all for joining us. And if you have any further questions, there is a Flux Forum site that you can join to ask questions. You can also reach me through the Micropulse website, and I do consultations for people. If you have any questions, please feel free to reach out to us, and we'll see you in the next video. Thank you. Thank you, Dr.